Yeah. Yes. ಎರಡು ಕೇಸ್ ಇದೆಯಾ?
One
ಎರಡು
Sania.
ಕೇಸ್.
Yes,
We
sir.
had actually planned for one, but today one surgery was done, so we thought we'll quickly discuss that also.
Okay, okay.
Sania,
Yes.
quickly.
So you mean today's OT case we're talking about, sir?
Quickly.
Okay, sir. So he's a 79-year-old male patient, got admitted initially like 3 weeks back for abdominal pain and distension. He was tolerating orally, but he had not passed stools for 2 days. Along with that, he had left lower limb cellulitis. Patient was treated for left lower limb cellulitis. On giving laxatives, he passed stools after giving enema, and his distension came down, and patient was discharged. After 3 days, he came back to emergency with complaints of breathlessness, abdominal distension, again not passing stools. He was admitted and evaluated. Again, on giving laxatives, he had passed stools and his distension came down, but his respiratory issues aggravated. So he was admitted under physician and evaluated for the same and was treated. Eventually, he deteriorated, became very drowsy, and underwent aspiration. He was Riles tube was inserted and he was started on Riles tube feeds. And he was diagnosed to have aspiration.
Hold on. You said underwent
Yes,
aspiration.
yes,
What
sir.
aspiration?
Yes. He was on RT feed, sir. He had taken soft diet. After he passed stools and his abdomen became normal, he was allowed soft diet.
No,
That
no, no,
soft
no.
diet,
I didn't understand. You meant what aspiration?
aspiration of the food.
Aspiration pneumonia.
Okay, okay. He underwent aspiration. I thought like he has undergone some procedure.
No, sir. He
Okay.
developed aspiration pneumonia.
Developed. Okay,
And
okay.
yes, sir. And and that was treated and he improved.
Any
Sir?
comorbidity? Any
So he's
comorbidity?
diabetic, hypertensive, hypothyroid, and IHD, sir, on treatment.
Okay.
So after the aspiration pneumonia episode, he started developing fever spikes. Again, started having abdominal distension, not passing stools. So gastroenterologist was involved. Injection neostigmin was given. He X-ray showed distended sigmoid colon. Like a kind of volvulus picture, sir, but not a complete coffee bean appearance. And following which they did a neostigmin was given, but it did not improve much. So colonoscopic decompression was done once. During colonoscopy, Purnachandra sir observed that the sigmoid was very much distended. So following which we planned for exploratory laparotomy and proceed, since the patient had repeated episodes of obstruction. And
No,
sir,
any CT.
yes, sir, CCT also showed distended sigmoid colon and rectum, sir.
Only distended sigmoid colon and rectum, not the entire colon.
No, sir, not the entire colon.
And no volvulus.
Volvulus as such, they had not mentioned, sir.
No, not mentioning. Have you seen the CT? Did it show any evidence of volvulus?
Sir, that's what.
No evidence of volvulus. It was just the distended sigmoid and the rectum.
Sigmoid colon, rectum.
No evidence of obstruction. They reported it as like adynamic presentation, sir.
So Nishant is asking, could it be part of sepsis? Is this part of sepsis? But if it is sepsis, there should be dilatation of entire small and
Yes,
large
sir.
ball. Just why localized sigmoid and rectal dilatation?
That's what, sir. And they also mentioned that the sigmoid was very redundant.
Right.
So the patient was taken up for laparotomy today. Sir, I'll try to share the picture, sir, in top, if possible.
No, but what was the reason for isolated sigmoid colon and rectal dilatation?
That's what, sir. Could it? Hello.
If it is isolated rectum and sigmoid colon, how can you explain that? If it is due to
The redundant sigmoid, it's a very redundant sigmoid. Going in for
redundant sigmoid also, it will not be like isolated dilatation. It can go in for volvulus, recurrent volvulus. Then that can lead to obstruction.
but there was no volvulus as such, sir. Even CT didn't report volvulus.
But how do you explain that only rectum and sigmoid colon was dilated? not the other part like the descending colon, transverse colon. If it was something like something physiological which has caused it.
Yes, sir. I'm not sure of that,
Sir,
sir.
This is the sigmoid, huh?
Sir, yes, sir. One more other picture is there. Nikita's third picture. This is the specimen, sir. Introp you show, Nikita. This was the dilated sigmoid, sir.
grossly distended. So there is no
Yes, sir.
obstruction on
No, sir, no obstruction. It was not even like it's a little dusky, not
it.
going in for obstruction or anything, sir.
Was it fecal
I'm
loaded?
not loaded, sir. Only when we cut the ends, little amount of fecal matter came. It was not loaded.
Okay.
Even colonoscopy was done day before yesterday only, sir. Like yesterday, it didn't show any fecal loading. It was, sir said it is very much distended.
No, if it is only this much distended and that too isolated sigmoid colon, it should be
Yes,
a
sir.
volvulus, like closed loop obstruction. Then only it can dilate so much.
So, but closed loop obstruction, so many episodes, you would have gone for gangrene by now, no, sir?
No, it might be like on and off, like partial volvulus. How will
That's
you
what, sir.
explain dilated? How will you explain such a dilated sigmoid colon? That too only sigmoid colon.
Sigmoid and rectum also was dilated, sir. But
This the
isolated, I'm not sure.
ileum was
No,
not there,
I
not causing ileosigmoid knotting or anything.
no, sir, nothing.
Was the small bowel dilated?
No, sir, small bowel is also normal. Small bowel,
Surprising.
transverse,
Distending
and even
colon.
descending colon was normal, which we brought out as colostomy, sir.
Cecum and all this were normal.
Yes, sir.
Hmm. Nishant,
He
anything to comment? Hello.
No, sir, nothing that I can think of, but a very difficult decision to make regarding surgery. My only
Yeah.
thing is, sir, in colonoscopy, if they could have completely decompressed the gas,
No, they would
probably
have.
they could have.
No, I have done this many times. I have decompressed, and within 12 to 14 hours, the colon again distends. Why that happens, we don't know. I have actually, against the gastroenterologist had refused to do couple of patients in the ICU, and I have decompressed them. For
Okay, sir.
24 hours, the distension is off, and then again it distends. So it's
One
very
of the
difficult to say why
one of
this
the
is happening.
pathophysiology is in ICU patient basically because of the bedridden status, the colon and in elderly with multiple comorbidities, colon goes into kind of rest without any
Yeah, yeah.
movement.
So I think what Nikita had pointed out, this man was demented also. I
yes, sir.
think the dementia is probably the cause for this. These people have redundant sigmoid and also, as Niranjan suggested, maybe partial volvulus, which is why there was relief occasionally, and then again it would go into distension. So I think with the resection of that sigmoid, maybe he will do well now.
Nishan, pseudo obstruction, it will be full generalized dilatation of
Ah,
entire
entire
along
small
with the
bowel
small
also.
intestine,
Small
along with
bowel
the
and large bowel.
ಇಲ್ಲ sir,
which is not
isolated sigmoid colon pseudo obstruction irutte sir. Andre because of that nerve, if
Ah,
the like neuropraxia sort of thing that happens,
yeah.
so there are certain cases. So just thinking, could that also be one of the reasons?
Yeah, that could be, but whatever I have seen, I think we will have to look at the literature. But
but
whatever I have seen, as Niranjan
additionally
suggested, the
not
entire
kind of
large bowel will
dilatation
be like dilated.
kind of
Ogilvy syndrome.
this
Ogilvy
is kind
syndrome.
of mega this is kind of a mega colon ತರ ಇದೆ. It's so usually dilated pseudo colonic obstruction ಇಷ್ಟೊಂದು dilatation ಆಗಲ್ಲ.
Ah, ade.
Sir, and you pointed out this ileo sigmoid colon knotting, no, sir.
Ah,
In that, it will be an acute obstruction, no, obstruction, no, sir.
it will be acute obstruction.
Because there was a loop of ileum along with appendix which was adhered to the mesentery of descending colon, which sir had to release a little so that we could bring it out, but
So
not
I
to the
think I
sigmoid as
think
such, sir.
I think that might be just luckily it was partially obstructing
Yes, sir.
and derotating itself, which is why
I know,
he.
sorry Sania, but that is proximal, no descending colon.
Proximal.
It should
Yes,
be
sir.
distal.
Proximal. Yes,
That
sir.
cannot
No,
cause
I just wanted to know that the knotting causes acute obstruction, no, sir. So many
no,
Yeah,
multiple
not in cause
episodes of
acute
partial
obstruction, and
obstruction can't happen.
that will be more distal rather this what you're talking about is proximal.
Yes, sir. Yes, sir.
So I think we are not any wiser about the cause of the problem and the this one future. I think the hopefully with the release of obstruction being relieved, the abdomen becoming softer, maybe the stenting of the abdomen will diaphragm will be less, and he may recover from his pneumonia also. We'll have to see.
Yes, so
Well,
with this given picture, what could be the cause of pus it was frank pus in the peritoneum? Again, could it be because of the diverticula only that you suggested, sir?
I think that because as I said, translocation of bacteria will not cause pus like that. It is usually translocation is into the bloodstream and they will have bacteremia and septicemia, but they won't
Yes,
have pus in the abdominal cavity. I think it might have been a small diverticula which had perforated previously, and which is
yes, sir.
probably what has caused this the pseudo obstruction or dilatation of the sigmoid.
But before causing that pseudocolonic obstruction, it should be causing some amount of peritonitis with guarding or rigidity or
Yeah, but
elevated counts or something. No, sir, nothing of that sort was there.
79
He
year
did
old 79-year-old demented diabetic, he may not be able to mount an inflammatory response.
manifest. Okay, sir. Okay. Okay, sir.
I think the extremes of ages, it's very difficult to the ability to localize infection is less, and ability to mount an inflammatory response is also less. So that is
Okay,
the
sir.
problem with the extremes of ages in small kids
Yes, sir.
and very elderly people, and especially comorbidities add to the problem also.
Yes, sir.
So that is the stoma.
Yes, sir. Yes, sir.
So you've done what laparotomy? You've done a
Left
transverse,
eye. Yes, sir. Transverse.
left iliac
Almost
fossa.
left iliac. Yes, sir. Left iliac fossa.
Okay, right. What is the advantage of this, Nikita?
But were you able to clearly assess the transverse colon and this thing with this instrument?
Yes, sir. Yes.
Very low down.
Yes, sir. We could. We could, sir. His abdomen was very, because of the distension and all, once the sigmoid was brought out, his abdomen was quite stretchable, sir. So when once retracted, we could see descending colon and transverse colon also.
Nikita,
Sir,
what is the advantage of an incision like this? And what is the disadvantage?
sir, disadvantage would be what sir just now commented, sir. Visualizing the
Correct.
right
Rest of the
ascending
ball.
colon and the
Rest of
transverse
the
colon.
ball. Yeah, rest
And
of the ball.
Rest of the
also, why drain? And that too in
Sir,
that
here,
position.
because
First was the
what pus was no, sir,
Where?
subcutaneous little bit pus was there in the peritoneal cavity, sir. We have put an ADK also left on the right side. Here, sir,
No,
put
no.
a drain
this is
because
Where is this?
corrugated.
yes, yes, corrugated drain, sir. Why? Because sir has brought
Corrugated.
out that descending colon through the main incision. And then tunneling through the subcutaneous tissues done to bring out the colostomy there. Initially, sir was planning to bring out through the main incision only, sir. But because it is close to the left, like left groin, it becomes difficult to put his colostomy back. That's why subcutaneous tunneling was done, and then the stoma was brought little up, sir, on skin side. That's why
No,
sir
but
kept a
why?
drain if there's any collection.
If you tunnel it reverse way, will it not cause obstruction?
No, actually, sir, when sir put skin incision is here. Then sir retracted the skin incision and muscle incision is little higher up under the skin. So it was easy to bring out through this, sir.
You
Like
said it
hardly
was
two.
main incision and then it has been tunneled.
Yes, sir. Two centimeters of tunneling into the subcutaneous tissue, not so as far
That
as
is
seen here,
what.
sir.
So if it is like a U-shaped this thing and it is come out,
Yes, sir. Yes, kind of little small U.
will it not cause obstruction
So
in the stool?
when I tried to dilate this loop, my finger was going in easily, sir. There was no acute
No,
bend
no,
or
no.
anything.
I'm not talking about finger going in easily. Finger will go in easily because there is lot of distance between the incision and the stoma. I'm talking about the thing which will happen over a period of time because it has come through the main incision and it has gone up. Will the stools be able to move in that direction, sir? Your opinion?
Yeah, I can't fathom what actually has been done. It's difficult to.
What she is telling
Sir,
is
sir.
it has been brought out through the main incision and then subcutaneously it has been taken
Yeah,
upwards.
there can be kink and angulation, so there can be potentially obstruction.
Why
Sir,
it
that
had to be done like that? Why not
sir, the
direct one?
angulation. the angulation is not as much as it looks here. So the distance here between the skin incision and the stoma looks very far. But inside the muscle incision that was made, it is proximal to the skin incision that is seen, sir. Skin was retracted and then muscle incision was made.
No, no, my question is why not a separate small incision there and bring out the
Yeah,
stoma?
yeah.
So because that it would eventually come out through the same muscle layer, sir.
What same
Because
muscle
the,
layer?
Yeah.
the
Yeah,
muscle
same.
under the skin, sir, and the skin is very distal. The
Oh,
skin incision.
I think it is probably a permanent stoma, correct?
Yes, sir. It
Or
is
you're
a
going to,
permanent.
yeah,
No,
it's a
sir.
permanent.
Permanent. Yes, sir.
So if you're planning a permanent stoma, why create a proper this thing incision upper part,
Refine.
the
Refine.
thing
The
proper incision, and why not that I'm asking why it
the
had to
same.
be brought out through the same incision tunnel and bring it up.
The tunneling is not too much, sir. Hardly 1 or 2 centimeters.
No,
What
no,
I'm
even
telling
1 or
is,
2 centimeter. Why I'm asking, what I'm asking you is, why not a fresh separate incision for a stoma? Because the
sir,
Yes.
incision, which is their main incision, is not an ideal site for stoma. It is
correct,
way
sir.
down and it will
So,
come in
but
the way of the bag.
correct, sir. So whatever stoma is there now, that is an ideal site, no, sir.
That
No,
is the
it is
ideal
not.
site.
Huh. So the
That is,
muscle incision is 1 to 2 centimeters below this below the
that
stoma
should
only, sir.
that should be little down. Whatever the stoma is there, the line connecting the umbilicus to the anterior superior iliac spine. It should be in that center there, where you are pointing out, little bit there,
Okay,
in
okay,
that
yes, sir, yes,
in
sir,
that area.
yes, sir. But I didn't feel any acute bend here, sir, when I
No,
because
it will not manifest now because the finger will go
eventually,
in.
sir.
I'm not talking about the obstruction near the stomal exit area. I'm talking about the
Uh, Near
uh,
the
uh,
muscle when you're telling when the turn is taken upward, no, sir.
yes, whether the tools will be able to negotiate that bend.
I
Sir,
think
there is no actual bend as such. The muscle
no,
incision is
no.
Is there
I
a bend
think
here,
no. The
ma'am?
no,
lesson
no,
lesson to
Nikita.
all
I
of you
don't
is
have a pointer here.
don't do whatever this has been done. It's not ideal. You know, you may get
Okay,
away
sir.
with it, but it's not ideal to do what has been done. So that is the lesson. See, whenever you are doing
And
a stoma,
that too when you are planning a permanent stoma.
as
Temporary,
Lakshman sir, last class he's talked about placing the stoma in the right way. The planning the stoma, the incision, all these things. What we have spoken. This is not the. This would not fulfill the in the tenets of proper stoma, but it's been done. So anyway, if it works, it's good for the patient, but it is not the way to do the stoma. So that much is you have to understand. And what sir will be able to get away with, you will not be able to get away with, I'll tell you. So it's for example, sir has brought out stoma through the main wound, which is a definite no-no. But he has managed to do that, and patient has got better also. So I think there is an element of luck in all these things, and if you are not lucky, you will get into a lot of trouble. So what Niranjan is saying is create a separate refine and bring out the stoma, especially because it's a permanent stoma. The way it has been matured is very good because there is an element of just like an ileostomy. So the stoma will sit nicely into the bag, and one, it won't retract, and two, it will not cause any stenosis because the way it has been created. So that is good. But the kinking bit of it, it's even 1 or 2 centimeters. Maybe hopefully for his sake, let us hope that it won't happen, but it can potentially happen.
Sir, if I can ask a few questions, sir, why was
Yeah,
it a midline laparotomy done? What was the indication for doing a?
sir does all these things. He
Okay.
he
sir
tries to
prefers
think.
sir
Transverse incision. He
prefers
prefers transverse incisions for the reason that he thinks that because the
hernias
transverse
are
incisions heal better. So which is why he does
Okay.
that most of the time. He does it for even for colonic resections and things. He does transverse incisions.
Yes, sir. And for a benign condition like this, why was the decision of a permanent stoma taken, sir?
Because of his age, his diabetes, comorbidity, and a long-standing illness, aspiration, he was not very well. I think he was in ICU
And
on
But
inotrope.
but we still have the option of reversing if necessary. So
sir,
as of now, it
the
is
dilatation was there up till the rectum, sir.
I think rectum also is
Initially, sir,
dilated.
planned in the resection anastomosis only
how,
because of the huge dilatation of the rectum and the complete rectum, sir, planned a permanent stoma only, sir.
how much of the rectum is left behind, Sanya?
Uh, Sir, almost the whole of the rectum only, sir. We removed only sigmoid.
Yeah, so the rectum is still there. So potentially
Yes,
it
sir.
can still be a reversible condition.
It can be,
But
but at 79, you wouldn't want to
Understood,
do
sir.
a Hartmann's. Yeah,
Yes, sir.
you wouldn't want to reverse a Hartmann's.
Okay, sir.
I,
And
I,
Sanya,
I,
yes, sir.
last
Yes, sir.
point, you were saying that your finger went in easily, you're not feeling the kink. I
Yes,
understood
sir.
what you're trying to say. But the
Yes, sir.
problem is patient is under GA, under muscle relaxation. So at that point of
Possible,
time,
sir.
automatically it'll feel like it is normal. But like what
Yes, sir.
Niranjan sir said, better to avoid kinks where it comes like a J shape.
Yes, sir. Yes. Okay.
Yeah, that's what he was trying to say.
yeah.
Yes, sir.
So,
Nishant, I think probably we are not sure about the causative factor.
yeah,
So it
yeah.
is better. So it is better.
Lot of question marks, in
Hmm.
So, Nikita, the question I asked you about why transverse incision.
One for the better visualization, sir. Like we know that it is a sigmoid colon pathology. So the immediately will above that would be the ideal thing.
Okay.
Second thing, it is less chances of incisional hernia because midline is more prone rather than the
No, but at this age, you are not worried about incisional hernia. What are you more worried about?
pain also, sir. Pain is
Correct.
also less
Pain. See, pain and respiratory. See, when it is lower abdomen, no, very lower abdomen, the breathing will not be affected. So there is better chance for the patient to, have less pain and also to recover, and his respiratory, muscles will be not so affected. So potentially, he will have benefit of that. If you make a midline incision and the breathing because of the pain and the muscle in this one, he may have continue to be on ventilator and things like that. So it is better for that purpose, no doubt. Okay, you can
Sir,
present your second case.
just one thing, sir.
Yeah.
Is she justified in saying better visualization?
Um,
Midline is always because you can extend up, you can extend down.
no,
So,
sir.
but
Only
for
about the
sigmoid,
sigmoid. Only the sigmoid portion and
That,
the like
what if
descending
the
colon.
mesentery, see, where will the
Disadvantage.
mesentery come to the center? And what if you have to resect higher up? You have to go to transverse colon, hepatic flexure, splenic flexure, if you have to. See, right now you went in with a blind eye, right? Everything looked normal on CT. You only know it's sigmoid colon dilatation, but you still don't know what else pathology is there. Like you said, if it's a ilosigmoid knotting that had happened, even that had to be resected.
the sir's incision almost comes close to midline. So,
That is
whatever
not
mesentery is there,
that is not justification. I'm just saying that. Can you justify saying it is better for visualization? For this particular case, I'm not questioning anybody's techniques, anybody's methods. I'm just saying your justification of saying better visualization, can it be justified for horizontal incisions?
No, sir. No, sir. Just before also we commented that it's a disadvantage that we can't see the ascending colon and the transverse colon. This is the what comment I made is only for the sigmoid portion, better visualization of complete sigmoid portion. That's it, sir.
Isolated sigmoid.
Isolate. Yes, sir.
Yeah. And second question, why less pain in horizontal incision?
Less tension, sir. In
No,
comparison
no.
to the midline, less tension.
No, not necessarily. Midline also tension free, we will close. You're cutting through more dermatomes when you do a vertical midline incision. Horizontal, you're cutting through a single dermatome. That's why the pain is usually lesser in horizontal incisions or transverse incisions. Done. Please carry on.
any questions on this patient? Anybody? Hello,
no, sir.
Nitya?
No, sir.
So, ma'am, this is sent for the histopathology, no, ma'am?
Yes, yes, sent.
Okay. Go to this next case. Nikita,
One second, sir. I'm resharing it. So this is a case of 61 years old male. He came to OPD with the complaints of swelling in the right groin noticed in the last 6 months, associated with dull aching type of pain, which is of recent onset, and it is intermittent, which is seen mostly on the long walking and straining activities. History of increased frequency of micturition at night since 1 year. No history of constipation, vomiting, or loose stools. Not a known case of any comorbidities. So patient was examined, conscious, coherent, and cooperative. Vitals were stable. No signs of pallor-icterus. Per abdominal examination, abdomen was soft, non-tender. A swelling of 2 into 3 centimeters was seen over the right inguinal region only during the cough. Otherwise, there was no obvious swelling. Left inguinal region was normal. External genitalia, no abnormality noted, no phimosis. So a clinical diagnosis of right uncomplicated inguinal hernia was made. Patient was planned for surgery. On evaluation, ultrasound abdomen was done, which showed cholelithiasis and grade 2 prostatomegaly. So what should we plan is the question.
Okay.
Shall
Praveen.
I continue or sir? Yes.
No, wait. Praveen,
Yes, sir.
if you are faced with this situation, patient has come with right inguinal hernia, and he's incidentally has is shown to have cholelithiasis. What will you do?
Sir, we'll counsel the patient, sir, regarding the cholelithiasis. And if he's agreeing for the surgery, then we'll take up laparoscopically. First, we'll do the hernia. Then we'll plan for, we'll do the cholecystectomy, sir.
Why is one? First of all, has he got any symptoms at all relating to his gallbladder?
Presently,
No,
no,
sir.
sir.
Did you question he had any pain, dyspepsia,
Yes, sir.
acidity?
Retrospectively, we questioned him. There were
He
no
did not
complaints
have.
associated. It was an asymptomatic cholelithiasis.
Asymptomatic. Is he diabetic?
No comorbidities,
No,
sir.
sir.
Okay.
Multiple or
Are
solitary
you,
goals?
are you justified in
Multiple.
offering cholecystectomy for him? What does the current literature say when you have two pathologies? What is the current literature review say, Nikita?
Sir, I just went through the recent systematic review, sir. This is of 2025 systematic review. So, even in case of cholecystitis or asymptomatic cholelithiasis, they said it is safe to go ahead with the both procedures. The incidence of complications are very minimal. And mesh infection is not reported in any of the cases in this systematic review, sir. Most of them were just like routine hematoma and seroma complications. No mesh infections were seen. So,
Okay.
with such evidence, we can actually advise them to go ahead with cholecystectomy.
You can, as you rightly said, but which one will you do first? And what are
It's a
the
hernia we
safety?
should.
Hernia, sir.
Sorry?
So, 2 points are here. Hernia we should to be done first. One, in view that it is the primary complaint of the patient. Second thing, if we finish the surgery, hernia and close it, and then do the cholecystectomy. If any complication in the cholecystectomy occurs, we can abandon the procedure and come off.
But what if bile leak happens, sir? We have
How
already
will,
placed
how will
mesh.
you abandon the procedure?
Sir?
How will you abandon the procedure if any complications happen during
Like if it
cholecystectomy?
is difficult, we can avoid it, sir.
What if you injure CBD and there's bile leak during cholecystectomy? You've already placed a mesh.
But peritoneal area is already closed,
See,
no, ma'am.
that is
Like,
But
that is
that
what
won't be very strong, no?
in these scenarios, if it is preferable, it is better to do extraperitoneal repair. And if you're not okay with the extraperitoneal, you can still do a tap repair, and then since you have closed the peritoneum, you can do the cholecystectomy. But as Sania said, bile leak happens, it's unfortunate thing, then there will always be a risk.
But
Okay.
Nitya,
Yes, sir.
would you do hernia first or would you do gallbladder first?
Sir, technically speaking, first should be gallbladder because even if
No technical.
No
Here,
tech.
I think what Nikita said is absolutely right. The patient has come to you with a right inguinal hernia. So you have to address what he has come with. Incidental cholecystectomy. So you can't, and I think do the hernia and repair and get the peritoneum closed properly and then go for the gallbladder.
Okay, sir.
Nishant, your views?
Sir, I absolutely agree with what Nikita said, sir. Always what the patient needs first. And Sanya, with your questioning of what if you injure the CBD, the same way, what if you injure the external iliac artery? Do an open hernia, then why do you want to do laparoscopy? So they're
No,
all
sir.
part and
What I mean is, with the mesh in place, if some amount of bile leak
the,
happens, won't there be
yeah,
a chance of infection? Is the
right. And idea
What is
is
your answer to that then?
if
Sania,
it,
would you
sir,
then
sir, if I
remove
may
the
just finish.
gallbladder and leave the hernia as such?
no, sir, not like that. That
I'll
was my
answer.
question. If how do
Yeah.
we go about it if we injure them?
I'll answer your question, Sanya.
Yes, sir.
Ideally, not see in this patient it is cholelithiasis. So the bile is still sterile.
Yes, sir. It's
The bile is still
asymptomatic, correct?
sterile. Okay, it is not an acute. In the presence of an acute, that an acute cholecystitis will take precedence over the hernia, and you can always choose to do the hernia at a later date. In
Okay,
this
sir.
scenario, if you have a bile leak, give an isolated wash. That means don't completely push in 1 liter of saline and then try to suck it, because you might try to push the bile down.
Yes, sir.
So in an asymptomatic case, you don't expect too much bile leak also to happen. When I say bile leak, you're talking about that bile leak from a torn gallbladder.
Yes, sir.
So
Yes.
just give a limited amount of wash, let's say 40-50 ml, suck it back immediately. Again 40-50 ml. Try to, as much as possible, try to keep it localized to the right subhepatic space as much as possible.
And also
Okay, sir.
in that scenario, give a 3-day course of antibiotics.
Yeah, prophylactic will not suffice.
Okay. Sir, what about will the same apply for umbilical hernia doing IPOM along with
Same. Yeah, yeah.
lap chole, sir?
Yeah.
Just
Yes.
Yes.
wash.
But in that scenario, you can't do an IPOM plus and then go for lap chole because your ports probably will
Yes,
come
sir.
in the way.
Yes,
So
sir.
in
That's
that scenario, probably you have to use a two different set of instruments. Take out the gallbladder without rupturing anywhere, or put it into a bag and take it out, and then plan the IPOM plus with
IPOM.
another procedure, like
Okay, sir.
another set of instruments.
And if you're very worried, you can always convert it to TEP,
Yes, sir.
because you would have done the gallbladder first. And
Yeah,
then
Yes,
you'll
sir.
be
TEP
Yes.
for
coming to umbilical
open,
hernia.
open retrorectus repair.
Yeah.
Yes, sir. Yes.
Shall I go ahead,
Yeah,
sir?
carry on.
Yes. So medical management was planned for the prostatomegaly as of now. So the patient underwent the planned procedure. Hernia repair was done first. It was a direct inguinal hernia, and then a cholecystectomy. Surgery was uneventful and hemostasis was
Why
confirmed.
was the
Patient was,
patient catheterized preoperatively?
sir, because of prostatomegaly, we were expecting urinary retention, sir. He already had symptomatic like nocturia and all. Only in that point of view, we
How much
catheterized
was the
to,
post-void residue?
sir.
How much was the post-void residue, and whether uroflowmetry was done?
Uroflowmetry was not done, sir, but post-void residue was around 100 cc, sir. Grade 2
Okay.
prostatomegaly with 100 cc, and patient was symptomatic,
And what was
increased
done for that?
frequency. Sir, we
He
just
was
started on
on
medication,
medication,
sir.
sir.
Urimax, sorry, sir. Urimax he was on. He just started before the admission.
How many days prior?
Maybe a week or so, sir. Not exactly sure. When he was evaluated, he was planned, and surgery was posted approximately a week after the OPD consultation. So, is there any particular period that Urimax needs to be used before surgery, sir?
There is
Hello,
no
Sir?
particular this thing. At least like the 100 ml is quite significant. I'm not sure. They needed probably further evaluation. Sir?
Yes, in such a case where there is a inguinal hernia, should we first deal with the prostate and then go with hernia, sir, or with medication? Can we go ahead with
I think so.
hernia?
Better take a urology opinion because 100 ml is quite significant.
Yeah.
Yes, sir, and him having now nocturia also.
Yeah. That is what.
See, uroflowmetry and this one, a lot of cognizance has to be paid for the significant residual urine. So I think uroflowmetry and I think urology opinion will tell us whether the prostate has to be dealt with surgically or medical management. I think proper
Okay,
urology assessment and opinion should be sought. Okay, carry on.
yes, sir. So, post-operatively, POD1 was uneventful. Patient mobilized well, tolerated oral feeds. Police was removed and patient passed urine. He was asked to wear a tight underwear and he was planned for discharge the next day. But on POD2, patient developed swelling of scrotum, right side larger than the left, which was progressive and associated with mild dragging pain. So patient stayed back for observation and pain management. What could be the probable explanation for the swelling?
Praveen,
Hematoma,
Anyone?
Praveen,
Yes, sir. Seroma formation and hematomas.
seroma will not happen so quickly, man. Post-operative
Hematomas.
day 1, day 2.
Hematomas.
Hematoma. Hematoma is most likely. What are this was a tap or
I
tap?
think tap, sir.
tap, sir.
So, what is the likely cause for hematoma, Praveen? Nikita? Hello?
Sir,
Hello?
hello, sir.
Tell me.
Sir, injury to the vascular structures like during the dissection, injury to the
No,
artery to
hematoma.
vas deferens, testicular artery.
No.
Yes.
Hematoma is scrotal hematoma. You're talking about hematoma in the wound or scrotal hematoma?
Sir, hematoma was in the scrotum, sir.
Okay. So what is the likely
There is
this one
no, sir,
injury?
because it's laparoscopic ports.
Yeah.
Hernial site was fine, sir. There was no
Hmm.
cough impulse there. Only the scrotal swelling was present.
Okay. So bleeding, as I think Nishant has pointed out, it can be bleeding, during surgery and as injury to the, vessel to the testicular artery or vessel to the vas deferens, or this cut sac. The sac, if it is been not, if completely retracted onto the peritoneal cavity, if the sac is cut and the cut end from the sac can bleed. So all of these things are the reasons for hematoma in the thing. If it is the hematoma in the inguinal region, then you have to think about the inferior epigastric artery injury.
Sir, this was a direct or an indirect defect, sir?
Direct,
Uh,
sir.
Oh,
direct.
It was
then why
direct
scrotum?
intraoperable.
Okay.
Okay, anyway, the story will unfold. Okay, carry on. So proper explanation, seroma. Seroma is not so early, ma.
Not
Seroma
But
is
early.
much
Yes,
seroma
sir.
is what, day 2? I think it is too early for a
too early.
seroma.
Yeah, it is hematoma generally. Okay, recurrence as
Early
this one.
recurrence of
And
hernia should
very
also
Nikita,
be ruled out.
Nikita,
lab.
Nikita, my question was, what was the size of the testis? Testis, whether
Size
there
of
was
the
testis
testis, sir.
enlargement whether there was testicular enlargement along with the scrotal enlargement. You
Sir,
got my
on
question?
POD2, there was no, yes, sir, yes, sir. There was no testicular enlargement, sir. Like, we couldn't
So no
appreciate that.
testicular, no testicular
No,
pain
sir.
or anything.
No, sir, no, sir. There was just mild dragging pain. There was discomfort to him because of the swelling.
So I
Okay.
Testicular
think
enlargement or swelling was not there.
what Nishant said, and I think all of you have to be aware of, is in laparoscopic hernia repair, I think the recurrence, when it happens, it can happen very quickly. That is in the first day itself. So you have to be aware of that fact. It could be recurrence also. Don't forget that. Okay, carry on.
So on POD through scrotal swelling further progressed. What should we do right now? Like should we plan any imaging or intervention? Any
Of
other
course,
investigation to be done, sir?
What was the hemoglobin, CBC, hemoglobin and all?
Sir,
Was
hemoglobin
there
was
any,
repeated. It
was
was
there
fine,
any,
normal, similar
any
to the pre-op value.
was
There
there
was
any
no
signs
drop
of,
in hemoglobin.
was there any signs of bruising in the skin and all that?
No, sir.
Okay, only swelling.
so,
Only swelling. It almost doubled to the next day, sir.
Ainas, would you do any investigation if you are faced with a situation like this?
Sir,
Hello?
Aina's is on call, sir, today. I think
She's
she's
not
in.
there.
She's not there, sir.
Samir?
Ultrasound, sir.
Huh?
Ultrasound.
Ultrasound.
Yes, sir.
Ultrasound, what will it tell you?
Hello.
Where is it?
Yes, sir.
What will ultrasound tell you?
Sir, about the hematoma, sir, if it is like any communication is there, any
What communication?
like any recurrence of hernia also can.
No, recurrence, clinically you can make out if there is recurrence. Praveen, what will the ultrasound tell you?
That content in the swelling, sir, whether it is serous or a hemorrhagic content,
Okay.
and probable source, sir.
It won't tell you the source. But it
Whether
will
it
tell
is,
you about the status of the testis, as
yes, sir.
Niranjan was asking. See, when you are in the post-operative situation, it's difficult for you to assess the status of the testis because it is tender anyway. So you don't know whether the testis is viable as well. So you have to look at that blood supply to the testis. Is there any, is the the Doppler color Doppler of the testis to see if there is any injury to the testicular vessels, and that can cause hematoma and also the pain. So you have to look at the status of the testis also whenever there is swelling of the scrotum. So these are the information it will tell you. Okay, right. Carry on.
Sir, just a small correction, sir. Actually, we did TEP on that day, sir.
Okay.
TEP was done for the inguinal hernia repair. There was a small rent in the peritoneum. Then post cholecystectomy was done as usual, sir.
Okay.
Pneumo
Right. Okay.
peritoneum. And
Okay.
so
Carry on.
ultrasound was done, which revealed 50 to 60 cc of collection, query seroma, no evidence of hernia. This is the testis, and in front of it is the collection, as we can see in the ultrasound image. It was around 50 ml.
Okay.
So, what would be the plan of management with the 50 cc collection? Is the question, sir.
What would you do?
Sir, if as the collection is just 50 cc and the patient is also not symptomatic, we can still go ahead with some observation. It will
Patient
resolve.
is symptomatic.
Sir?
He complains of discomfort. No, he's got a lot of discomfort, right?
Sir, but
no, you can manage him
there is no
conservatively. That is not the point.
significant pain. Yes, sir.
The point is, you said the patient is not symptomatic. He is symptomatic, which is why you did the scan in the first place. He is symptomatic, but it may be managed conservatively. 50-60 ml is not so much. You can definitely manage it conservatively. So what did you do?
Sir, patient was under observation with
Nikita,
antibiotic cover.
was it only the ultrasound or abdomen or only scrotal ultrasound?
Sir, it's only scrotal ultrasound, sir.
Why not
Groin and the
ultrasound?
scrotal ultrasound. Patient had no abdomen symptoms, sir. He was stable with, that's I mentioned. He was tolerating orally, bowel movements were fine, no pain abdomen. Abdomen was soft, no distension, sir.
Okay.
So, patient was under observation with antibiotic cover and scrotal support. Otherwise, he was doing well. On POD 5, 2 days later, repeat scrotal Doppler was done in view of progressive scrotal swelling, which showed 150 to 200 cc collection, query hematoma and edematous spermatic cord and scrotal wall. The second image shows the scrotal wall edema, which is very significant in comparison to the previous pictures.
Yeah.
Now the plan of management.
As suggested by Ravi Shankar, was to do an ultrasound scan of the abdomen also. I think what Niranjan suggested also is the same thing. Correct?
Ideally, yes, sir.
Ah,
But we went ahead with like
exploration.
patient was taken up for scrotal exploration
Okay.
to relieve the fluid. So an incision was made over the right groin at the root of scrotum, and 100 cc serous fluid was drained out along with 20 cc of hematoma material. Drain was placed and primary closure done. Scrotal support was applied. Drain output on POD 1 was yellowish, slightly bile tinged was the suspicion, sir. The image shows the drain output of POD 1.
No, why didn't you
So
get this
now,
doubt when you drained serous fluid with very little hematoma? How can you expect so
it
much
was,
amount
it
of serous fluid? No, my question, Nikita. See, the
yes,
idea of doing it was because you assumed there's a hematoma, correct? That's the reason you went in for scrotal exploration.
yes, sir.
And the minute you see 100 cc of serous fluid with very little hematoma, that too on post-op day 5, why didn't you think of something else?
Sir, it was thought maybe there was a hematoma all along and it slowly got absorbed
In
and
No,
5
only the
days.
it
In
won't get
5 days.
absorbed, so it won't happen. Hematoma takes anywhere between 2 to 3 weeks for it to completely get absorbed and become serous. So this wouldn't happen. It is just fluid. I think the fluid was probably bilious at the time. Okay. Carry
could be,
on.
sir.
Huh.
Yes. So the next thing, the drain fluid, because of the bile tinge, we sent it for analysis, which showed 66 milligram per deciliter of bilirubin. And the serum bilirubin also was done to look for any systemic increase. It was 2.4 milligram per deciliter. So suspecting some biliary collection or leak, ultrasound abdomen was done. Mild free fluid was seen in the subhepatic and paracolic gutters and right iliac fossa, which was insignificant. Patient was just under observation, but as the drain output was not coming down and it was still around 100 ml each day, on POD 4 of the second surgery, MRCP was done to look for the biliary. So MRCP findings, it showed thin fluid layering at the gallbladder fossa, and there was no obvious biliary leak. There were just post-operative changes and mildly prominent CBD and mildly prominent pancreatic duct were seen. So no further evaluation was or intervention was done as the patient was asymptomatic, but the drain output was significant till then. Patient was under observation for the next 2 days. Drain output gradually decreased, and patient was discharged on POD 7 with the drain. A review was done after 3 days, and the drain output was relatively low, and it was removed then, sir.
Okay.
So the
Right.
questions would be.
Where is the bile leak from? That is the first question.
Yes, sir. Is it the bile that collected into scrotum? That was proved by the fluid analysis. It is bile, but how did it get there, and what is the source of the leaks, sir?
Yeah. So what is the source of the leak? So who diagnosed bile leak? I think Niranjan already had that as one question, but I think sir asked me what should you do and what should I do, and I told him get an ultrasound scan. It will be bile leaking from the gallbladder fossa, layering along the paracolic gutter and coming into the iliac fossa. So that is what exactly was what was shown on this ultrasound scan, and then subsequently the MRCP. But the probably it is a I think who was there in surgery for gallbladder?
Sir, me and Nitya ma'am were there, sir.
Okay, so was there any problem during surgery as far as bile duct or anything is concerned?
No, sir. It
No,
it
sir.
went on very smoothly.
Okay, so it is probably where is the leak from then? The leak is from one of the cholecystohepatic ducts, the ducts of
Accessory bile duct, the duct of
ducts of
Lushka.
Lushka. If there has been no obvious bile duct injury, then it is most likely because many times you won't be able to see these ducts and bile leak happens from there. And fortunately, it is self-limiting. It settles down on its own as the fibrosis happens, the duct closes. So
So
now,
here the main panic thing was that once we got to know it was bile, we were very worried about the mesh, sir.
see that Nishant has already answered that question for you
Yes.
So, but
because
bile was there in the scrotum.
yeah,
Initially, maybe it was sterile. Then we opened the scrotum, we did the evacuation. That itself would be introducing some infection, no, sir, into the bile. And the
Yeah.
drain placing there, won't that cause infection? And that,
Right now, right now, him having a bile leak should be more of a headache than you being worried about if the mesh will get infected.
yes, sir, but ultrasound and MRCP showed no significant leak also, no, sir. Why 200 ml of collection was there?
Like sir
How will
said,
we?
a small duct which is opened up, which is fibrosed.
Okay,
So
sir.
probably that is where the leak has happened from. And are you absolutely certain it's no bowel injury? Can't explain bowel injury also. That look like golden yellow bile.
and
Yes,
they
sir.
have done TEP, so it's unlikely.
Mhm.
The
But
other,
second surgery would add in potential chances of infection, no, sir.
yeah, but that space you have gone in is not again the space where the mesh is.
But there
Because
is a but there is a tract through which the bile is flowing from the peritoneum into the scrotum. So the same tract could be that will obviously be through the mesh, no, sir. If it is
yeah,
coming
Yes.
into the scrotum.
but you would have probably covered it with antibiotic, but there is a potential chance, no doubt about it. There is a small chance that mesh can get infected, and
Yes.
we'll have to wait and watch. I think hopefully you won't have had any problem.
Yes, sir.
So, what are the lesson from the? What is the lesson from this, Nitya?
Sir, one thing is if the patient is asymptomatic, I mean, better not to deal. If the patient is asymptomatic, then better not to deal a gallbladder with the hernia, sir.
That is in retrospective analysis. Yes, you may be right, but I think the as the the evidence has been shown by Nikita that potentially the mesh infection is not so much. It's not been a problem at all in any of those common S1 cases that I have done. So current evidence suggests that it is possible for you to safely go ahead and do both the procedures, but always there is always a small possibility something like this will happen, which is very rare, but it has happened in this case. So I don't think you can take many conclusions from this and say I will not do gallbladder at all from now on. But you have to be careful. I think that's definitely something you have to be worried about.
Sir, once the bile output was more in the initial stages, why
Uh,
wasn't ERCP thought of?
I think
It was.
Because MRCP was normal, Antana.
Yes, sir.
uh,
Yes, sir. Once if
so
MRCP had shown a significant leak, sir was thinking of planning an ERCP to stent the leak or
Okay.
any further
I'm
intervention.
not sure, but Nikita, can you just find literature on whether MRCP can pick up small leaks? I'm not sure. I'm asking you. Can you just look it up and let me know, please?
Yes, sir.
Like, for example, your RBC labeled scintigraphy and all what we do for obscure GI bleed, right? All those depend upon the rate of bleeding. Unless it is more than 5 ml per hour or something, even if the bleeding is ongoing, you don't pick it up with those tests. So is there something of that sort of a condition for MRCP also? Can you just find out and let me know, please?
Hello, sir.
that's a very valid point. I think
Hello.
Sir, sorry, when to intervene, sir, if this bile, if it is coming even after 2 to 3 weeks, then?
No, you have to intervene. You have to intervene early.
At
And
what time, sir, particularly? Because MRCP is showing normal.
yeah, the thing is, if the bile leak continues, you have to do as this one Nishan suggested. It may not potentially pick up minor bile leaks, so you do an ERCP, and also also the problem is, if the system is under high pressure, then the leak will continue. So you are better off doing a sphincterotomy and putting a stent, and that will reduce the pressure in the system, and even if it is a duct of Lushka or whatever, it will stop. So I think if the leak it goes on for a period of 1 week, I think you should definitely consider doing an ERCP and sphincterotomy and possibly a stent. In this case, because the leak stopped, that is why the ERCP was not considered. Okay, any questions? Carry on, ma, Nikita.
Yes, sir. Sir, review of I looked for this similar kind of cases, sir, but they had some unrelated but similar presentations. One case was reported in 2006 where there was acute scrotum with bile post laparoscopic cholecystectomy. So it was in a young male who had hydrocele, sir. Like congenital hydrocele was there, which was diagnosed later on when they went to treat the acute scrotum. So through that, there was bile going into the scrotum. And there was one more case of perforated gallbladder in which acute scrotum has developed. And there is one spontaneous CBD rupture case, sir, in a very elderly male. That also resulted in the scrotal and inguinal region uh, bile collection, also called as scrotal biloma. No similar case as ours has been reported as of now, sir, as of what I checked.
But Nikita, here, I think you have created the track between the scrotum and the peritoneum, because you told me there was a rent when you did the ETEP procedure. You said there was a small peritoneal rent.
Yes, sir.
And the fact that there's a hernia, probably you have created the communication to allow the bile to reach the right hemiscrotum.
Yes, sir. The whole tract is all iatrogenic, but the question is, sir, though they have done in the systematic review almost around 400 to 500 cases of cholecystectomies with inguinal hernias were done, but none
No,
of them
no, no,
have
no.
reported such collections.
No. The point is, these references, whatever you have put up, is bile in the scrotum with patients who have undergone hernia repair? No, this is
With
just direct.
cholecystectomy,
This is
none of them are hernia. Yes, sir. That's what, sir.
So there are two separate scenarios, right? Here you have created the tract and allowed the bile to go into the scrotum. That is why his bile was collecting there. Otherwise, the bile would have collected in the abdomen. Patient would have presented with peritonitis.
Yes, sir.
So when you say no case is similar to ours is being reported, you can't report it along these lines.
Sir, but it is one of the complication associated with the two surgeries doing together. But
But
such
had the
complication is
peritoneum
not
been,
reported yet.
there was not. But if there was no rent, I don't think it would have manifested this way. It would have,
It,
like Sir said, it would have been just a localized peritonitis that would have happened, I feel, sir.
See, Nikita, what I'm trying to say is you have allowed the bile to reach the scrotum. That was iatrogenic.
Yes,
It was
sir.
not a spontaneous collection of bile in the scrotum is all that I'm trying to say. That's all. The
Okay, sir.
other cases are where it is spontaneously gone into the scrotum, right?
Yes, sir.
Yeah, probably there was an undiagnosed hernia in those patients.
Yes, sir. Yes, sir.
Yeah. And second thing, Nikita, why do you think that you didn't find the bile leak on table? Why do you think it started 2 or 3 days later? Are you there?
Yes, sir.
Huh. Sometimes you might have a thermal injury. You would have used your clips, right? And
Yes,
when you're
sir.
cutting off, you can have current jumping. It would have hit one of the clip. The clip would have probably touched some small duct in the liver bed. That would have burnt. You would have had a thermal injury, and the thermal injury would have opened up about 48 hours later. So even though everything looked very uneventful on table, there is a chance that this could have happened.
Got it, sir.
And in some inadvertent injury to the bile duct, small injury may start leaking bile at at later date, at a
Yes,
later
sir.
time.
Hmm.
Yeah, yeah. So I think interesting situation, and high index of suspicion was required to make the diagnosis. Any questions or clarification?
No, sir.
Hello?
No, sir.
Okay. Final comments, Niranjan and Nishant.
Two mind-boggling cases, sir. We still, I have to go read about it.
Sir,
Niranjan?
can we say that can we consider that peritoneal rent was in a way helpful for us because this minimal amount of leak, if there was no peritoneal rent, then would it have gotten diagnosed at a later date or something like that? Can we say it's like a serendipity or
No, no,
like
no. You can't say because you don't even know. The thing is, it's just happened. I don't think you can say
Yeah,
serendipity, it is lucky or whatever.
it's all speculations as of now.
Yeah.
okay, sir.
Niranjan, final comments. Is it there?
Anyway, both good cases for this one, sir.
Sir, my question is, if there was a peritoneal rent, then why did it collect in the scrotum? It should never collect in the scrotum, Avaga.
There was a rent in the peritoneum, sir, during the TEP also. There was small
No, no.
rent.
If there is a rent in the peritoneum, it should not collect in the scrotum. No, it should come out into the peritoneum.
Huh?
No,
My
sir.
argument
When
is, if there is a rent in the peritoneum, it should not collect in the scrotum. It should come back.
it's a rent in the peritoneum communicating to the TEP plane where sir has placed the mesh. From there into the scrotum, sir.
And
No, you have such a large space. You have a rent in the peritoneum. The same way it's going in, it should come back.
Allah,
Why
scrotum
should it?
probably is a dependent area, Allah, sir.
ಅಲ್ಲ ಅವನು ಎದ್ದು ಓಡಾಡ್ತಾ ಇದ್ದ ಅದಕ್ಕೋಸ್ಕರ the bile was flowing down the paraphoric
Dependent.
gutter and dependent. That is why it was going there. And that rent in the peritoneum helped for the bile to get into this space.
Otherwise, nothing, sir.
Okay, so I think two good cases. I think the main thing you have to understand is you have to have very high index of suspicion, and it is very difficult to make decisions about elderly patients who are, whom you don't know what is happening. Investigations do not lead you to anything. The decision to operate, especially in the face of patient on a ventilator and inotropes and things like that, it's very difficult. Again, post-operative situation, assessment of the patient becomes difficult. You have to have high index of suspicion, and I think you have to have an element of luck to manage these patients properly. I think that is the take home message. Okay, if there are no further questions, thank you all for a very enlightening discussion and this one, and thank you. Good night.
Thank you, sir. Good night, sir.
Good night.
Good night.